días. Gracias por la invitación a Madrid, a GESOC. Es un placer para mí estar aquí, but my Spanish is not enough to give my lecture in Spanish, so we have to switch to English. I'm sorry. I was asked by the moderators to talk about a very interesting topic. Topic is dry eye, a progressive disease. When we look at the definition of dry eye, it says that it is a loss of homeostasis, that we have symptoms in our patient, that one of the major problems is tear film instability, hyperosmolarity, inflammation, and neurosensory abnormalities. So when we look at progression, we may have progression in all these symptoms and signs of dry eye. But what do we look at? Do we look at increased symptoms when we want to judge progression? Do we look at increased tear film instability or increased tear film osmolarity? Is ocular surface damage the thing we are looking at? Do we want to see an increase or a progression in inflammation? And do we want to see more redness in those eyes? Or do we want to judge this from tests like MMP9? Or is increased corneal nerve damage the measure we want to use to judge progression? It is very difficult to see dry eye as a common condition because there are so many different groups of dry eye patients. We have the postmenopausal dry eye patients. We have patients after surgery, after corneal refractive surgery, after cataract surgery. We have dry eye patients that have their dry eye associated with skin disease like rosacea or autoimmune bullous skin disease like Stevens-Johnson, mucous membrane pemphigoid. And we have patients that have disease associated with autoimmune disease. It's not always the same condition. Another fact was already discussed this morning. Signs and symptoms in dry eye patients do not correlate. A systematic review of 34 clinical studies found a low and very inconsistent correlation between clinical signs and patient-reported symptoms. The correlation coefficients were low, indicating a very low to moderate correlation, and also these correlations were very inconsistent. One of the reasons is that the disease is variable over the day, over the weeks, over the years. However, there are other things that influence the perception of dry eye. It's the psychology of our dry eye patient. When we look at patients with a high discordance between symptoms and signs, as seen here in this slide, these patients also have a very low perception of their health. These are the patients that have massive symptoms but low signs, a massive discordance of signs and symptoms, and they also have a very low self-perceived health. The highest ranked significant predictors of those patients who have high symptoms and low signs are other chronic pain syndromes, atopic disease, fibromyalgia, or the use of antidepressants. And we know that part of our dry eye population may show signs of dysfunctional somatosensory pathways, indicating also neuropathic ocular pain. So do we want to also look at these patients when we look at progression of the disease? How about borderline dry eye disease? Patients who have intermittent symptoms, symptoms worse on wakening, worse in the evening, symptoms triggered by air travel, by draft of air, by room heating or wind. Does it stay borderline in these patients, or does it gradually get worse? At the moment, we don't know. Often dry eye is associated with an underlying disease. And these underlying disease or condition can also wax and wane. For example, autoimmune diseases like Stevens-Johnson, mucous membrane pemphigoid, connective tissue disease like rheumatoid arthritis, dermatological diseases like rosacea, or continued use of drugs, including drugs with preservatives and especially glaucoma medication. When we look at the dry eye workshop report number 2, it says definitely that at the moment there's insufficient evidence to include progressive in the definition of dry eye disease. It says, clinically dry eye is often described as chronic and progressive, although there is currently insufficient evidence to support inclusion of these terms in the definition. While omission of these terms from the definition is warranted at present, additional research, including dry eye natural history studies, should be performed to inform future refinements to the definition terminology. At the moment, the progression of dry eye disease has not been evaluated in long-term prospective clinical studies. So what evidence do we have that there is progression in dry eye disease? When we look at epidemiology, there seems to be soft evidence, at least, that there is some progression, because we see that there's an increasing prevalence of dry eye with age. In the age range of 18 to 49, we have a prevalence of only 3%. In higher age groups over 50, the prevalence increases up to 11, 12%. And it's, I think it's very nice to see that the female patients are definitely the ones that are involved in a much higher rate in these older ages than the males. Also, when we look at meibomian gland disease, meibomian gland dropout, lid margin abnormality scores, we see that they positively correlate with age, they increase with age, and again here, it's very interesting to see that here the female preponderance does not exist anymore. Here, even male patients are the ones that suffer from meibomian gland disease more than the female patients. When we look at pathophysiology, what evidence do we have for progression here? We have learned that 5 key mechanisms are existent in dry eye disease, and they compose a vicious circle of dry eye disease. It is possible for the patient to enter this vicious circle of dry eye disease at any point and to complete the circle several times. However, it seems that in some patients, it's not only a vicious circle, but these patients end up in a vicious spiral with constant worsening of the disease. It's interesting to look at the natural history of dry eye disease, looking at aqueous deficient dry eye and evaporative dry eye. And Tony Braun did this and predicted the natural history of these 2 types of dry eye disease. So when we start looking at aqueous deficient dry eye, we have a decrease in lacrimal flow. However, when the whole situation decompensates, we also have an increased evaporation rate, leading up to a hybrid phenotypes of dry eye, leading up to a patient that does not only have an aqueous deficiency, but also an evaporative dry eye. And the same is true for evaporative dry eye, where we have an increased evaporation rate with time. However, in the time of decompensation, the sensory loss from the cornea also leads to a decrease in lacrimal flow, and again to a hybrid phenotype of dry eye. Also, we have learned that homeostasis becomes progressively unstable in our dry eye patients. And one very good homeostasis parameter is osmolarity. It is very stable in normals, is only slightly variable in mild dry eye patients. However, when we look at severe dry eye patients, there is a massive temporal variation in the tear film osmolarity, also indicating that homeostasis with time decompensates. We have looked at MMP9 positivity in the tear film in patients with dry eye, and we could clearly see a correlation of a positive MMP9 test increasing inflammation with disease severity. Another indication that we may have progression in dry eye disease is that we have a corneal nerve loss over time in our dry eye patient, with a decrease in nerve density associated with an increase of inflammation and increase of influx of dendritic cells in the corneal stroma. So what is the clinical evidence for progression? Leonard and co-workers looked at a group of patients, and they attest subjective worsening of dry eye disease, subjective progression of dry eye disease in 24% of their patients for ocular surface symptoms, in 29% of their patients for vision-related symptoms, and in 10% for the social impact. And this worsening, or this progression, was especially seen in those patients with past severe dry eye disease symptoms, and this was true for the for the ocular surface symptoms, for the vision symptoms, and also for the social impact. Also, it was significantly associated with a higher load of monthly costs for dry eye treatment and the use of systemic beta blockers. So we have, at least from the subjective symptoms, we have some evidence that there is progression in some patients. When we look at a very specific group of patients, Sjögren's patients, there is also evidence that there is progression, especially in these severe dry eye patients. 771 patients were enrolled in a collaborative clinic alliance registry, and they were examined at baseline and after 2 or 3 years for a follow-up. And it was interesting to see that Sjögren's syndrome, the underlying disease, progressed over the study time in 9% of the patients, and it was associated with hypergammaglobulinemia and hypocomplementemia. But what's interesting for us ophthalmologists, that also ocular surface staining values increased over that time period significantly. An interesting fact is to look at treatment failures. Here you see patients that had either artificial tears, the gray bars, or cyclosporin A, the black bars. A number of patients did not show any change. A number of them improved. However, some of these patients, despite treatment, also worsened. The worsening was significantly higher in the group with artificial tears, but there were also patients who worsened with their signs and symptoms being treated with a very good anti-inflammatory treatment. And especially interesting is to look at those patients that were switched from cyclosporin A to artificial tears. Here the worsening or the progression increased significantly. I said before we don't really have very good data at the moment to prove progression. However, there's a very good study underway at the moment. It's called the PROOF study, Progression of Ocular Findings study. It is a prospective study to evaluate the natural cause of dry eye disease. The study design and the baseline data were already published in 2017, and the hypothesis of this study is that dry eye disease is progressive and influences ocular surface health, quality of life, and visual function. And the results are expected after 5 years. So this is a big study, a multi-center study, prospective, controlled, observational. It includes mild to moderate dry eye patients treated with artificial tears versus controls. And it includes 217 patients and 67 age and sex-matched controls. Unfortunately, at least I think for us Europeans, this study is only conducted in the US in 26 geographically diverse US study centers, as you can see here in this map. So the primary endpoint of this study is the percentage of patients with signs of dry eye disease progression, either having an increase in corneal staining or the new development of central corneal staining, an increase in symptoms, or especially an increase in blurred vision. These are the primary endpoints. And there are a number of secondary endpoints. For example, the percent of patients who are discontinued from the study because they need another therapeutic intervention. Or patients that increase a lot in symptoms, patients that decrease in their Schirmer's test, or patients that have a reduction in reading speed. So very interesting also secondary endpoints of this study. So in conclusion, progression is not yet at least included in the definition of dry eye disease. Dry eye disease progression is difficult to prove. What do we take? Symptoms, signs, which sign? Dry eye disease is not a single condition. Progression may only be present in certain subsets. And we've heard this morning from Victor Perez that, for example, patients with ocular surface disease in ocular graft versus host disease, they are progressive and they have inflammation in 100%. This may also be true for patients with Sjögren's syndrome, but we don't know for the others. Dry eye disease perception and perception of progression is influenced by pain perception. We have a disconnect of signs and symptoms, and there may be patients with neuropathic disorders. Dry eye disease progression may be associated with the progression of the underlying disease. However, the natural history studies we have at the moment indicate that about a quarter of patients with dry eye disease have progression of ocular symptoms and signs over 2 years. We have learned that hyperosmolarity, inflammation, and changes in corneal nerves are closely related to disease progression. It seems that compensatory mechanisms seem to work in mild stages of the disease, but seem to decompensate with progression. Especially in Sjögren's syndrome, we have seen that the ocular surface staining definitely increases over 2 to years follow-up, indicating progression. And a subset of dry eye patients progress despite treatment, and higher numbers progress with withdrawal of an effective anti-inflammatory treatment. And I hope that the PROOF study that currently evaluates progression of dry eye disease will be available soon, will be available in about 3 years, and will give us some more support that dry eye is a progressive disease. Thank you very much.